What is cystic fibrosis?
Cystic fibrosis is inherited commonest life-limiting illness in Caucasian population. It is inherited as autosomal recessive pattern. It is a monogenic disorder, meaning thereby that it is caused by a defect in single gene. That gene is located on chromosome 7 and it is called cystic fibrosis transmembrane regulator gene, and that is responsible for making protein for chloride channel that regulates movements of chloride and sodium across cells. Due to defect in cystic fibrosis transregulator gene, chloride channel is not formed or not functioning properly, affecting the movement of chloride and sodium across cells, resulting in thick and very sticky viscid secretion. And in layman term, I can say thick mucus in the airways and pancreatic duct and other part of the body. And once there is a thick secretions, that may give rise to a blockade of the airway, leading to increased bacterial growth and recurrent pneumonia, or you can say recurrent lower respiratory tract infection. At the same time, once the pancreatic ducts are also blocked, there will not be secretions in the pancreas which are responsible for digestion of the food, and that's why it will cause a maldigestion of the food. And this is all about cystic fibrosis.
What are the signs and symptoms, and at what age does cystic fibrosis normally present itself?
Okay, as I said, there are major defect is in the formation of chloride channel, so it doesn't function well, and that's why there is a thick viscid secretion. So what happens if there is a thick secretion in the respiratory tract, that is, you can say in a layman term, phlegm, that cause choking of the airways, and that result in the increased bacterial colonization, mucosal inflammation, and mucosal hypertrophy. That result in a recurrent lower respiratory tract infection or pneumonia, ultimately resulting in a damage to the lung, and in medical term, it is called bronchiectasis. So this form of illness may manifest in the first few months of life. And the other thing is thick viscid secretion in pancreas. So blockade of the pancreatic duct leads to blockade of this juice coming to the intestine, and that leads to a pancreatic insufficiency, and that will lead to a poor digestion of food. It may manifest even when the baby is in utero or during pregnancy, and that may manifest at birth in form of meconium peritonitis, in which the patient may not pass stool. Generally, a newborn should pass a stool within 24 hours. But if a child is passing beyond 24 hours, then one of the reasons may be cystic fibrosis. Subsequently, during childhood, preschool, and school going, there may be steatorrhea, or you can say that fatty stool, that is in form of a large, foul-smelling, bulky stool. And because the child is not able to digest the food, the child is not growing well. Same thing happens to the sweat glands, and because of the increased chloride and sodium content in the sweat, if a child, the parents may notice that it is a salty kiss, though it is not commonly observed by the parents, but it may happen. In older children, it can be in form of during summer months, when the sweat dries up over the other parts of the body, including face, you may be able to find some salty crystals of salt on the area where the sweat has dried up. And during summer months, there may be dehydration, and the child in the beginning, around 3-4 years of age, may have a salt craving. So as you had seen, that it may manifest in utero or during pregnancy. So in the first 2 years of life, the common manifestations of cystic fibrosis are delayed passage of meconium at birth, may not pass stool at all, and that is called meconium ileus or meconium peritonitis. It is because the thick meconium or thick fecal matter, which is digested by the pancreas, blocks the intestine and that ruptures in utero. Then, after birth, there may be obstructive jaundice, there may be low protein, or in medical term, we say hypoproteinemia. Some children may have anemia, and it may affect the liver also at birth, leading to a bleeding disorder. And as the age advances, there is a fatty malabsorption, in which the child presents with large foul-smelling bulky stool, and in first 2 to 3 years of age, there may be prolapse of a rectum. That is, the part of the rectum comes out. Initially, it goes back spontaneously. Subsequently, parents or mother may have to push it back, and that is because of the decreased support to the rectum. Then the children may present with bronchitis, bronchiolitis, and recurrent pneumonia. Between 2 to 12 years of age, it is predominantly clinical symptoms include malabsorption, recurrent pneumonia, nasal polyposis that manifest as a nasal blockade, and in some children, there may be intestinal obstruction due to intussusception. And children beyond 13 years of age, there may be chronic pulmonary disease in form of a persistent cough, expectoration. There may be clubbing, which is indicative of a advanced lung damage. There may be abnormal glucose tolerance test because of the endocrine function of pancreas, but that happens after 10 years of age. And if it is a frank diabetes, then it is cystic fibrosis related diabetes. Then sometimes there may be chronic intestinal obstruction due to plugging of the intestine by the fecal matter. There may be effect on the liver as age advances, and it manifests in form of a focal biliary cirrhosis, portal hypertension. Some children, small proportion, may develop gallstone, and almost 98% of the adolescent boys may have absence of sperm, that is we call azoospermia. The other atypical clinical manifestation is important to understand specifically in Indian children is because of the delayed diagnosis. We do not expect that they are diagnosed in the neonatal period, and because of the adverse or severe environmental issues, very high temperature in some part of the country, there may be significant electrolyte abnormality in form of a low potassium, low sodium, and there may be alkalosis. And in medical term, we call them a pseudo-Bartter syndrome, in which there is a hypokalemic metabolic alkalosis. There may be, because of the low potassium during the summer months, the intestinal motility is reduced, and it is called meconium ileus equivalent, which may present like a intestinal obstruction. Majority of the children, by the time they are diagnosed, they may be colonized with Pseudomonas, which is one of the important bacteria which sooner or later comes in the airway or respiratory passage, and that is responsible for chronicity of the illness. Some of the children may have a deficiency of vitamin like A, D, E, K. These are called fat-soluble vitamin. Majority of children in India may have a low bone mineral density, and there is a high incidence of allergic bronchopulmonary aspergillosis. Some of them may be deficient in zinc, iron, and B12 at the time of diagnosis. And as I said, there may be increased chances of diabetes once they are more than 10 years of age. And almost 2/3 of the patient may develop depression once they are more than 15 years of age. So long-term complications or clinical features of cystic fibrosis are CF-related diabetes, CF-related liver disease, pulmonary hypertension as indicated by breathlessness on exertion, hypertrophic pulmonary osteoarthropathy, decreased bone mineral density, and depression.
Why are the warning signs of cystic fibrosis missed?
This is responsibility of the doctor. And because it was considered to be a disease of Caucasian population only and non-existent in India. That's why the doctors are not trained to look for cystic fibrosis, or they are not aware about the clinical symptoms of cystic fibrosis, like as you rightly said, delayed passage of meconium at birth. So majority of our pediatricians trained in country may not have seen even a single case of diagnosed cystic fibrosis, and that is responsible ignorance of the physician taking care of the babies. But over last 3 to 4 decades, cases have been reported from all over the world, and it is considered to be occurring in the non-Caucasian population. So this is mainly because of the uh, ignorance of the doctor. Second thing is, even if some doctor suggests that it may be a cystic fibrosis, then because of deep beliefs that it doesn't happen in non-Caucasian population, over last many decades, the diagnostic facilities have not been developed in India, and that we'll be discussing when how to make a diagnosis. So even if some doctor consider that it may be a cystic fibrosis, he or she is not able to ask for the particular test to confirm the diagnosis.
How should pediatricians diagnose cystic fibrosis?
So I would suggest that when a pediatrician or a physician who is taking care of the children newborn should suspect that I may be dealing with cystic fibrosis. So during neonatal period, if the baby has not passed meconium or first stool in first 24 hours, there is a meconium peritonitis as indicated by abdominal distension, not passing stool, and baby develops a neonatal cholestasis or neonatal jaundice. So these are the red flags during neonatal period, which may be because of the cystic fibrosis. Then during infancy, infancy is first 1 year of life. So a child or a newborn or infant presenting with recurrent pneumonia, and there is a history of malabsorption syndrome as indicated by child is passing large amount of foul smelling bulky stool with floats in commode because of the fat content. There is a low protein as indicated by the edema. There is say some anemia or less hemoglobin, and it may be because of the hemolysis, and some children may have a zinc deficiency. So if any of these things are there, think of cystic fibrosis. During toddler, which is between 2 to 5, 6 years of age, if a child is having a recurrent pneumonia, rectal prolapse, and not growing well, despite good appetite, it may be one of the reason may be cystic fibrosis. And during school going age, if there is a recurrent pneumonia, not growing well with bronchiectasis, think of cystic fibrosis. During adolescence, it may be again a chronic respiratory problem, not gaining weight, delayed puberty, and then of course steatorrhea as indicated by large foul smelling bulky stool. Some children after 10 years of age may develop clinical features suggestive of cystic fibrosis related diabetes, and as I said, there is an increased incidence of allergic bronchopulmonary aspergillosis. So if a child presenting with allergic bronchopulmonary aspergillosis, one of CF may be one of the reasons. During adult, apart from chronic lung diseases, if someone is having a subtle clinical symptoms of respiratory problem but not having babies, or you can say sterile due to azoospermia, CF may be one of the reason. Chronic liver disease and diabetes may be other things. So if any of these things are present, uh, the physician should have a high index of suspicion for cystic fibrosis and should be ruling out it by appropriate investigation.
When should parents suspect that cystic fibrosis is the problem?
What happens is that whenever they are sick, down with pneumonia or respiratory problem, then, or if they are having a dehydration, then they are not looking well and they may not drink or eat. But otherwise, they have a good voracious appetite. So if a child is getting repeated problems and when he recovers, he is having a appropriate appetite, and despite good appetite and eating well, the child is not gaining weight. In those situations, parents should become suspicious. And if specifically if there is a history suggestive of sibling death or other sibling having the similar problem, or if some communities in India have a marriage within the family or blood relation. So if those things are there, along with that, child is having a voracious appetite, falling repeatedly sick, then think of cystic fibrosis.
How is cystic fibrosis diagnosed?
There is no such classification, but as I highlighted, the clinical features are variable as per the age. And in the beginning, it may be just a simple wet cough, and at age of 20 years, there may be significant expectoration or phlegm, along with that breathlessness or breathing difficulty. So that's why, though they are very variable clinical manifestation, and a physician should be aware about it. And it may be, one is because of the poorly managed respiratory passage and digestion in the beginning, or it may be because of the different type of genetic defect. I had discussed about pathogenesis, that there is a increased sodium and potassium in sweat. So we take that for the making a diagnosis. So we do a sweat test, estimate the chloride content in the sweat, and if it is more than 60 milliequivalent, along with clinical features, we are sure that we are dealing with cystic fibrosis. Other thing which we can do is identification of two mutations. Mutation is defect in the gene, genetic material. And if we can identify two, and I would like to clarify that since it is a autosomal recessively inherited disease, that indicates that the one gene is coming up, defective gene is coming from the mother, and another one is from the father. So because these two are together, that's why that is responsible for the disease, development of disease. And there are multiple defects in the gene. And this is another test, that you test the gene, and if you are able to identify two defects in the blood sample, then you are 100% sure that it is a cystic fibrosis. Problem here is that there are more than 2000 type of mutations or defect. Out of that, some of them are responsible for causing disease. That's why it is very difficult to test. For India, we say that sweat chloride or increased chloride in the sweat with a clinical phenotype are considered to be a gold standard for making a diagnosis. Another thing, as you were worried about how parents can decide that whether my child needs investigation for cystic fibrosis, is that at AIIMS, we developed a test that is called aquagenic wrinkling, in which just let me explain that what is aquagenic wrinkling. If I put my hand in water, after 10-15 minutes, it will show some wrinkling on my palm and as well as my uh, uh, these thing digits. So the children with cystic fibrosis, they develop this wrinkling within 3 minutes. Almost 81% of the children may develop early wrinkling, but it may be due to cystic fibrosis as well as due to multiple other causes. So this can be used as a, if the child is having a recurrent pneumonia, not growing well, and if parents notice that there is a very early wrinkling as compared to the other sibling, then it may be indicative of a cystic fibrosis.
How can parents of cystic fibrosis patients manage them better at home?
I'll be discussing about how to manage at home and what is the responsibility of parents. But as I said, sweat chloride remains the gold standard for making a diagnosis of cystic fibrosis in India, but it is not available freely in most of the centers or in most of the hospitals. So in that situation, research carried out at AIIMS have made a simple algorithm using clinical symptoms and basic laboratory tests which may be available to most of the physicians. And that include that if a child is having recurrent or persistent pneumonia with bulky fatty stool or not growing well, if two of these things are there, then we take a history, that whether there is a history of sibling death due to respiratory illness or his sputum culture at any time was positive for Pseudomonas. If it is there, then we are reasonably sure that we are dealing with cystic fibrosis, and we start the treatment and subsequently do a sweat test for confirmation of the diagnosis. If these things are not there, in that situation, we do, as I described, aquagenic wrinkling. We put the child's hand in a water for 3 minutes and see if there is a wrinkling. We do a blood gas in which there is a low sodium metabolic alkalosis. We do a stool test for fat globules. All these three things, which are simple blood test and stool examination and aquagenic wrinkling, if two of these are positive, then we say that the child is suffering from cystic fibrosis and we can start the treatment. So
Okay.
now we discuss about this what is the responsibility of the parents and what is the treatment for cystic fibrosis. So as of now, there is no cure for cystic fibrosis. However, you can say that with supportive care, there is an improved survival from 6 months in 1950s to 45 years in 1920s. And it is only supportive care. And what is that supportive care? That I'll discuss one by one. First and foremost is that there is a thick and sticky secretions in the airway, or phlegm is very thick and secret, and that is choking the airway. So airway clearance and how you can do it, that I'll discuss in detail. So one is that we keep the child well hydrated. Well hydrated means the doctor generally tell the family that they should give adequate amount of fluid, along with that salt, common salt, and another salt is potassium. Once the child is well hydrated, the secretions are relatively less thick and viscid. Second thing is, generally the doctors will explain, or a physiotherapist will explain regarding how to keep the chest clear. So that is universal, that all children with cystic fibrosis will need chest physiotherapy morning and evening. And there are multiple ways of doing a chest physiotherapy. One commonly called is a postural drainage and chest clapping, in which child is kept in different position and it is explained to the family, mother, father, as well as other caregivers, that how to perform this chest clapping in different posture after giving some medication, including some nebulizations. Then there, because this chest clapping and other thing may not work in older children, so there are other ways that the physiotherapist explained, which include active cycle of breathing, positive expiratory pressures, flutter therapy, autogenic drainage, and high frequency chest wall oscillation. And as I said, chest physiotherapy is mainstay of treatment of keeping the airways clean and to reduce the damage to the lung. So in that case, doctor generally explains that what all medications may help in improving the airway clearance. And in India, generally we use hypertonic saline, that is 3% or 7% saline, after giving salbutamol to prevent any bronchoconstriction. So what happens is that a mother or father or caregiver gives this hypertonic saline after giving salbutamol, and then does the chest physiotherapy as explained by the physiotherapist. There is another medicine that is called palmozyme, that is not available and very expensive in India. So the first and foremost is that keep the airways clean by good hydration, salt supplementation, and potassium supplementation. Do a good chest physiotherapy, whatever has been explained by the physiotherapist or a treating doctor. That is important. Morning, evening, it has to be done. And there is no replacement by any medication or any injection or other medication. The other thing is that the parents should be able to identify that my child is worsening. That is indicated by increased cough, change in the nature of cough, increased phlegm or expectoration. There is a rapid respiration or some breathing difficulty. Child may stop eating as he was eating voraciously before this exacerbation. Then there may be child becomes lethargic. So if any of these things are there, in those situations, the parents should bring the child immediately to the treating physician. And then the treating physician will examine and decide whether the child needs just increase in the physiotherapy session or needs a antimicrobial or antibiotics. And antibiotics are given by inhalation route or by injections or oral. So as you can see, even for the respiratory management, there is a chest physiotherapy along with that nebulization, and then administration of various medications, identification of early exacerbation, as well as uh, giving plenty of liquids. So this is very demanding, and the mother has to do this thing full time in the beginning. Subsequently, children, once they grow up after 15, 16 years, they can take care of themselves. In addition, there is a regular medication. At least there may be 10 points in the prescription. So apart from this respiratory passage clearance and antibiotic, there may be doctor may prescribe about some treatment in form of a replacement of a pancreatic enzyme, fat soluble vitamin supplementation, and supplementation of the salt. Then there are some specific treatment for liver. If there is some problem of a liver disease, then a medication is given regularly. So it is a full-time work for the parents to adhere to the treatment that would improve the outcome of the children with cystic fibrosis. Over. Till few years ago, uh, it was being considered to be lethal disease, or it will limit the lifespan of the child. And with proper care, though it is expensive, I'll tell you about what would be the expenses for per child per month. So with the proper supportive care, then they grow well. There are less pulmonary exacerbations requiring antibiotic and hospitalization. There is an improved nutrition, like they grow like any other child, and there is a preservation of the lung function, and there is a less depression. So say 7 decades ago, the median survival for children with cystic fibrosis was 6 months, even in European countries and US. Now they are expecting that it may be around 4.5 to 5 decades, means 45 to 50 years of age. But we have to explain it very clearly that this is a median, or you can say in a common language that it is a average. It means half of them may have some problem before say 45 years of age, half of them may survive till 75 to 80 years of age. And with a good clinical care, by using all supportive care, we expect that the children should be surviving. Now this is about survival of children with cystic fibrosis in Europe and say Americas, and in countries where these medications are being supplied from the government or it is supported by the government. Even in our country, there is a good survival. At our center, we started uh, diagnosis of cystic fibrosis in 1993-94, and till now might have diagnosed around 900 children. And as of now, there are more than 20 years of age in 20% of the patients. Say if we are seeing say around 3 to 400 children now, then almost 20% of them are more than 20 years of age.
Wonderful.
So this is about the prognosis. Say our group is working for this thing, to how to make a diagnosis early, even in the resource constrained countries, for last 2 to 3 decades. And now say 4 5 years ago, we published this thing, and now it is part of say most of the textbooks, as well as people who are working in countries like India and similar setting, they are using it.
How can cystic fibrosis diagnosis be improved upon?
So there are tests which can test only that part of the gene which is causing cystic fibrosis. That is called uh, targeted sequencing. So there is one higher version that is called a newer generation sequencing, in which there is a targeted sequence of the CFTR gene, and that costs less as compared to the whole exome sequencing. So for testing genetic tests, one is whole exome sequencing, another is targeted, that you want to target only particular gene, and the third thing is clinical exome sequencing, in which similar clinical symptoms are there, and you are not very sure whether I am dealing with the cystic fibrosis, primary ciliary dyskinesia, primary immune deficiency. In those situations, you can go for a whole exome sequencing, or if it is very clear that the earlier sibling has died of cystic fibrosis, you can do a targeted sequencing for the cystic fibrosis alone. But otherwise, best thing would be to do a sweat chloride along with clinical symptoms, and that helps in diagnosis of cystic fibrosis.
What are the costs of managing cystic fibrosis treatment?
As I said, it is a symptomatic treatment, or we treat symptoms. So if we do a regular chest physiotherapy, we ask parents not to smoke at home, protect the child from the environmental pollutants. It doesn't cost anything. Once you do some X-ray, vitamin supplementation, salt supplementation, you do some physiotherapy, you use a nebulizer, then it may cost around 2,000 rupees per month. If you start giving a pancreatic enzyme supplementation, because that is the major defect in the digestion, microbiology cultures, and whenever required intravenous antibiotics, that may cost around 6,000 rupees per month. Then, as I said, you can give some inhaled antibiotic that will keep the germs or bacteria in the airways under control. And you may need to do a CT scan sometime. In those situations, the cost may increase to 20,000 rupees per month. Then, as I said, there is a medicine which will liquefy the sputum or phlegm so that the child can bring it out easily. That is called DNase or pulmozyme. And if we start using it in India, it may cost around 95,000 rupees per month because it needs to be imported. And then there is a recent advances in management of the children with cystic fibrosis. There are certain medications which may be effective in particular defective gene, that is called cystic fibrosis modulators. They mean once the child is taking it orally, then their phlegm is very thin and they can bring out easily, and that improves the quality of life as well as preserve the lung function. But that is not being marketed in India, and if we want to import it, then per month per child cost may be around 25 lakh rupees. As of now, it is not available in India.
How should families where cystic fibrosis is known manage future pregnancies?
Yeah. So this is, as it is very clear that it is a genetic defect. There is a defect in the CF causing part of the genetic material. So once a diagnosis of CF is made or suspected, we should get a genetic test done on the child. So we are aware that this is the defect which has been inherited by the mother and father. And parents should be aware about it, that there are 25% chances for each pregnancy that the baby may be affected with the illness. 75% chances that the baby may not be affected. It may be either carrier or a normal child. So in that situation, the first step is, if they are planning another baby, to get the test done on the current baby so that the defect is known. And when the pregnancy is between 8 to 11 weeks, then generally one test is being carried out, and that test will take some part of the baby by ultrasound guided from the mother, from when the pregnancy is there, from the baby's part by ultrasound guidance, and that is tested for the defect which was identified in the current child. If it suggests that yes, it may be affected, then the doctor will tell the family regarding that the baby may be affected or baby may not be affected. Then it is up to the family to decide whether to continue the pregnancy or to stop it then and there. It is very important that if some family has a child who is suffering from cystic fibrosis and something happens to the child, and then they lose contact with the treating physician, and then suddenly they come back with the second child suffering from the same problem. So they should be aware that they should not forget that the disease will recur in almost 25% of the pregnancies, and they should be aware, or they should tell, or they should contact their doctor that what can be done for the prenatal diagnosis. So if someone is marrying in the same blood relation, then defective mutation will be more or less similar in both the partners. And the chances of a baby getting these mutations, abnormal mutation from the mother as well as from the father, then the chances of getting the disease is more. That's why I said if someone is marrying within the blood relation, chances of defective genes in them is more, and the chances of baby getting the disease is more.
Does joining support groups for cystic fibrosis help?
Yeah, till few years ago, because the disease was not diagnosed and there were not many patients, the parents were taking care of the babies, buying all the medications, and there was no say information available about the details of this disease. Then people saw that once the number of babies were increasing, number of children with cystic fibrosis were increasing, then they saw that there are certain other conditions also for which there is a parent support group. Specifically, if you see thalassemia, if you see other rare diseases, hemophilia, and so on. So then doctors like me encourage families to make a group, and then they can help each other to begin with by helping each other, by increasing the awareness, and then increasing the awareness by education. Then in we encourage the group of parents with cystic fibrosis, and they made a cystic fibrosis trust, which is registered with Government of India as a society. And then now what they started for last few years, almost 10 years, they procure the medication from the companies directly. So it is almost 50% subsidized or at a discounted rate. And then it is being managed. Initially, we were helping them, but now it is being managed by parents and children who have grown up with the cystic fibrosis. So they have a social, these media, including WhatsApp group. They communicate with each other, and once a year they have a meeting. They buy the medication as per the order from individual patient, and then they take money and then they distribute it. There is so this is a Delhi based society, that is CF Trust. There is another organization which is much bigger, and that is a rare disease in India, organization for rare disease in India, that is ORDI, which is Bangalore based NGO, and they are taking care of CF as well as other rarer diseases, and they are doing the same or rather better services for these patients. Now the other group, other support which is started few months ago is by the Government of India. That is because there is a policy for rare disease support program from Government of India, and cystic fibrosis is one of the rare disease recognized by this program. So they do not provide too much of a money, but at a one time support, they give say 50 lakh rupees that can be used over a next 10 years. So 5 lakh rupees per annum, and they'll get the medication from Center of Excellence across India. And AIIMS is one of them. There may be Institute of Child Health in Chennai. There are various parts, including say some in UP, there is a SGPGI, and in Mumbai, in the KEM hospital. So these are some of the institutions where there is a center of excellence. So the doctor concerned who is taking care of the children should be aware that such help is available from Government of India, free, irrespective of their income, education, or their caste and their other details. So the doctor will fill a form, send them to the Center of Excellence, where the Center of Excellence committee will screen, and if they will get it reviewed by the experts. If they feel that yes, he can be given some support, then depending on how much support has been asked, it is being sanctioned. And then the patient may go periodically, say 2 to 3 months, to the center where he can collect his medications and then come back again after 2 to 3 months.
What clinicians in India should know about cystic fibrosis?
I would like to suggest to say physicians or pediatricians, as well as from some information from parents, that though we do not know what is the exact magnitude of problem of cystic fibrosis, as it is 1 in 2,500 in Caucasian population, very well described. But for Indian population, it has not been studied or described very well. So there are some studies, including studies carried out at AIIMS New Delhi, regarding what is the estimate of this disease. So as of now, there are some hypothesis or postulation that it may be somewhere between 1 in 2,500 to 1 in 40,000 live birth in India. So just to highlight that what may be the number of patients which a pediatrician may be seeing in a year. So if you say population of India is 1.4 billion, birth rate is 20 per thousand, and if you presume that there are around 600 districts, and a child with cystic fibrosis may survive for 5 years, and each patient may have 6 times pneumonia. So, and there may be around 50 pediatricians per district. So if we consider that it may be similar to that of a Caucasian population, 1 in 2,500, as I said, it is reported that it may be between 1 in 2,500 to 1 in 40,000. So we may be getting around 1,100 to 11,000 babies born every year with cystic fibrosis. That is a sizable population. And approximate number per district would be approximately, at a given point of time, if they survive for 5 years, then there may be around 100 children in a particular district. And in that case, if it is true, then a pediatrician may be treating almost 10 to 15 children with pneumonia who may be having an underlying cystic fibrosis. So it is important that he or she keeps this thing in mind, that if a child is coming with repeated pneumonia, think of some illness like cystic fibrosis or some other illness, so that we do not miss them. We make early diagnosis. That is the key for the better survival and improving the quality of life.